Good afternoon, everyone. So it's really a great opportunity to see you. This is our 9th years of CPAP. Started with a small idea, and every year have been doing it. So today I'm going to start talking about update on PPHN and the use of inhaled nitric oxide, and I will touch base a little bit about nitric oxide and premature infants. So I have nothing to disclose in relation to this lecture. So the objectives is to review the physiologic basics for diagnosis of pulmonary hypertension, then describe the ventilatory management of infants with pulmonary hypertension, and then identify the available therapy, and then we'll visit the evidence for use of inhaled nitric oxide in premature infants. This is the place where I work at. It's a Cleveland clinic, and so the NICU somewhere behind that glass there. However, as much as I'm proud of working at such a great place, it's a really huge place. Has its own zip code. There's 55,000 people and bridges in the entire town. I would recommend, if you have a chance to visit Cleveland, you will get impressed there. But really, my personal impression came from Dr. Wang, who really taught me everything related to respiratory care. You don't need to be as small as this neonate to learn from Dr. Wang. But so this is not a fellow, it's a patient. But really, we learned a lot from him, and I'm very indebted to his teaching. So if you hear anything good, that is Dr. Wang. If it is bad, it means that he was not paying attention. So the fetal circulation, as we know, it is blood coming from the umbilical vein, the oxygenated blood going into the right side of the heart. Then some of it will go to the left side of the heart, and then some will go to the right ventricle, and then we have the ductus arteriosus still have more shunting here. So primarily, really, you have in the fetal circulation, the shunt occur at the atrial level. And then secondary occurs at the ductal level. But the difference between the fetal circulation and the pulmonary hypertension, though the physiology is the same, but 50% of blood is in here in the placenta. So in the olden time, we used to call it persistent fetal circulation, but then we discovered it's a misnomer because you don't have 50%, which is the placenta. So when you're having the pulmonary hypertension, you really have, number one, shunting across from right atrium to the left atrium at the PFO level, and then number two, you have another shunt happening at the vascular level. So the causes are multiple, either prenatal, such as using certain drugs, and especially indomethacin we use to prevent premature labor or abort premature labor, or even the use of aspirin in the past, meconium aspiration syndrome, and then increased plus viscosity, anomalies of pulmonary venous return. But I really believe, do we really see much pulmonary hypertension as we used to see in the past? Like when you are in your fellowship, how many cases of pulmonary hypertension you saw, and then now how many you see? So currently we are more vigilant with management of term infants immediately after delivery, because there is part of pulmonary hypertension really occurs after delivery, not the baby is born with pulmonary hypertension. The typical scenario is the baby came with a little retraction or little tachypnea, then you still admit the baby to the normal newborn, and then overnight, baby stay there, tachypnic, and then finally the full picture of pulmonary hypertension occurs 12 hours later or 24 hours later. But currently, with the use of non-invasive ventilations, lots of these babies that we used to send to the normal newborn, they're now, no, he's a little bit tachypnic, send him to the NICU, and he stays on CPAP for a day or so, and then you abort the process of pulmonary hypertension. And I usually tell the fellow, I really don't worry too much about a premature baby. I worry the most about a full-term baby who's sitting 90, 91 in the delivery room. Currently also we use a SAT monitor in the delivery room. We didn't used to do that in the past, because a normal newborn, after 10 or 15 minutes, he should be sitting 99% or 97%. So when he's sitting 90, 91, I don't accept that, because this is the one that you wait, and then at the end, he will come back to you with a severe pulmonary hypertension. So I would like to just make sure to express my view that really we don't see that much of pulmonary hypertension because of saturation monitoring in the delivery room and the more availability of non-invasive ventilation, and also could be in-house calls for neonatologists that in the past you used to receive the call from the nurse while at home. Now you have a teamwork and a group of physician and respiratory therapists and nurses attending there. One of the other causes, that is the malalignment of pulmonary vessels, or what we call it the ACD, alveolar capillary dysplasia. This is just a slide for the alveolar capillary dysplasia. You can see two things. Number one, when you look to the branch of the pulmonary vein and the branch of pulmonary arteriole, and you can see the adventitia of the alveoli of the artery actually extend to cover the vein. So now the pulmonary veins are really structured by the adventitia of the pulmonary artery. And then the second, that is a number one characteristics. And number two characteristics, you see the capillaries has nothing to do or no relation with the epithelial cells of the alveoli. So actually all these capillaries need to be lined at the epithelial layer to make the air exchange with the blood. But here you see them, they are far away from the vessel, from the capillary. So the diagnosis, usually in chest X-ray, you don't see that much except for maybe decreased vascularity, or you can see the underlying disease, such as diaphragmatic hernia, if existing. Then pre- and post-ductal SAT difference of more than 15 points, but this is only when you have shunting across the PDA. But you can have pulmonary hypertension with shunting only at the atrial level, so you still have the desaturation. And usually the pre is higher than the post with 15 points. However, if you see the opposite, then that is transposition. One of the bedside diagnosis, if you see the pre-ductal less than the post-ductal significantly, more than likely until proven otherwise, you should worry about transposition of great vessels. Then blood gases, CO2 usually is not involved. It's only the low oxygenation. And on echo, you see the typical picture of the deviation of the right atrial and or ventricular dilatation with the deviation to the left side, and you can see tricuspid regurg, and so you can hear a murmur of the pansystolic murmur from tricuspid regurg at the parasternal region, and then right to left shunting at the PFO with or without the PDA. So the clinical severity will have issues here because many times it is so dependent on how are you managing it. So the one way is doing the oxygen index, which is you calculate it based on the mean airway pressure on the ventilator multiplied by the FiO2 and divided by the PaO2. So basically you can make any baby with a very high oxygen index if you are ventilating aggressively. So it's so dependent on the managing team. And that's the other one is the AA gradient, the alveolar arterial oxygen gradient, which really you have the inspired oxygen, which is 7 PO2 in the room air that we're inspiring, that's 760 minus 47 multiply by your FiO2. So if you are on 100% oxygen, you are inspiring PO2 of 713 millimeter mercury. And then the A gradient would be that 713 that you inspired minus the PO2 on the arterial side, but also minus the carbon dioxide that is accumulated into the alveoli. That is PCO2 divided by the respiratory quotient. So at the end, you really, when you are inspiring 100% oxygen, minus 50 for CO2 divided by RQ, that is 50 minus PO2 of 50. So you end up having an A gradient of 600 plus, and that's a baby really can be a candidate for ECMO, who's on 100% oxygen, whose PO2 is only 50. So the management strategies, so really we're talking about the minimal handling, avoid excessive manipulation, and that is one of the major issues when you have a baby who's really, when you suction him, he will dip down. When you touch him, he'll dip down, and then you find that every 5 minutes, somebody doing something. So this baby in a continuous agitation. So minimal handling and clustering of care is a key point. And then providing supportive care, making sure about the temperature, the saturation, the sugar, and the fluid intake. One of the other points, really, you cannot handle a pulmonary hypertension baby who's hypotensive. It's a fight. Pulmonary hypertension is a fight between your systemic circulation and the pulmonary circulation. So in pulmonary hypertension, the right side of the body, or the pulmonary side, would like to push the blood to shunt it to the left side. And what we are trying to do is to push back by making a strong systemic circulation pressure to prevent that flow from the right side. So that is really a relationship. So if you have a baby, the first ever thing you think of a baby with pulmonary hypertension, push a fluid, for example, 10 per kilo. You cannot afford a baby who is dehydrated or fluid depleted. So first thing, that make sure that the tank is full, like I have a 10 cc per kilo or 20 cc per kilo of normal saline at the very start, to start with, to make sure the systemic circulation is good. And then after that, you start either using the pressors to increase the systemic circulation or pulmonary vasodilator. So when it comes to ventilation, of course, using a pressure on the ventilator that's just adequate to move the chest. And many times we get trapped in this. We think that the ventilator function is to increase our PO2 and saturation, while really it is manufactured to move the chest up and down adequately. That's what the ventilator for. So how many times in our practice, if you are working at a referral center, you see a baby who's transposition, who's transported with a bilateral chest tubes for pneumothorax. You were laughing, but it does happen often, or maybe frequent. So baby has no lung disease at all, come with 2 bilateral chest tubes because the PO2 is low and the answer gave more pressure. So really, the ventilator function is to move the chest adequately, and you see the baby as if the baby is breathing comfortable. And once you achieve that, then you shouldn't ask the ventilator anymore and should find why the saturation is low or what is missing. Then you have the I time 0.5, and now actually we tend to use less I time. The ventilators now are very good, that really in the olden time, to build up the pressure, it takes longer. Right now, really the current ventilators, so I see a shift from 0.5 to 0.4, and then using the 40 breath per minute and the PEEP 5, and then we are monitoring the pre-ductal sets and not the post-ductal set. You can measure both, but really looking for a pre-ductal set that would like to, that is going to the brain. And then, of course, avoid hyperventilation. In addition to the problem of the lung damage, there is another problem. You are actually impeding the venous return, and that decreases the systemic blood pressure, so that is actually not helping. So the use of high-frequency oscillator ventilators sometime or often works as a second step, And then this type of ventilation, the high frequency pulse pressure ventilation that Dr. Wang, before switching from a regular ventilator to high frequency oscillator, you can actually, on the same ventilator, you can give a high rate as a high frequency, like a rate of 100, but then the I time need to go down to 0.3 so that you will have a 30-second I time and 30-second E time. And then the PEEP, again, we used to put a PEEP of 0 because they're in adherent PEEP because of the high rate. Although with the newer ventilator now, I start to use a PEEP of 1 because you can read the PEEP now on the screen. So when you are on a rate of 100 and 0.3, you can read the PEEP already, that there are PEEP that is built up there. So I guess the issue of the ventilation and hyperventilation, are we hyperventilating babies with pulmonary hypertension? Yes, no? Trying to keep CO2 in the 30s? Okay, so, so of course, this is 1978. 1978, JPEDS, Journal of Pediatrics, with this article that came from George Bacon and William Fox for Children's Hospital of Philadelphia. They actually reported their experience for babies who were going to have cardiac cath for congenital heart disease. So the babies moved to the cardiac cath, and then while doing the catheterization, baby was bagged. Probably there was no transport ventilator. So they pushed the dye, they found the baby has complete pulmonary atresia. There is no blood going into the pulmonary artery at all. Then all of a sudden, they found that the pulmonary arteries open up and perfectly normal pulmonary arteries. And then they push another dye, they found that the pulmonary arteries disappeared again. And they correlated that this happened while bagging. When you are really bagging aggressively, the pulmonary artery opened. And then when you are bagging slowly or not aggressively, then the pulmonary artery closed. So they take that to the NICU, and whenever they have a baby with persistent, at that time, fetal circulation or persistent pulmonary hypertension, they put the cath on the baby, so you can measure the pulmonary artery pressure, and you can measure the systemic arterial pressure with a UAC for umbilical artery line. And then they created this chart on some 25 babies or so. So you found here the PCO2. When the PCO2 with aggressive ventilation came down to a critical point, and I defined that critical point is around PCO2, around 25. When the PCO2 came all the way down, what happens that the pulmonary artery pressure, that is blue pulmonary artery pressure, dropped down below the systemic blood pressure. So the whole thing is a fight between the pulmonary artery and systemic. So once you create a situation to bring the pulmonary artery pressure less than systemic pressure, now the AA gradient is improving significantly. And they actually have that on 20-some babies who were reported in JPEDS. And then you can even argue before 24 hours of life, you can argue that you start to see that the pulmonary artery pressure is coming up again, and the situation is really turning down to worse again. But based on that report, it became a standard of care in the 1970s and early 1980s that we really need to bring the CO2 to that critical value less than 25. And of course, significantly, if you do that in the animal lab, immediately you can create this same physiologic measure. However, the lung doesn't need more than 24 hours of this aggressive ventilation to end up by having complete respiratory failure and getting into ECMO anyway. A couple of years after that, then Columbia University came, Dr. Wang, with their approach with the gentle ventilation with avoiding hyperventilation. and reproducing good results with that. So the avoiding of the hyperventilation, because overinflation of the lungs impedes the venous return, and that decreases pulmonary blood flow and decreases oxygenation. Also, overinflation decreases the cardiac output that will cause hypotension. That's one thing we don't need. Then overinflation of the alveoli can overstretch the pulmonary vessels that will cause increased pulmonary vascular resistance. So really, if you look, this is Cancella from Colorado, presented it in one of his articles, where you see when you are ventilating appropriately balanced ventilation, here's the thickness of the pulmonary vessels will look this way, capillary. But when you are overinflating, you are overstretching the vessels, so you end up having thinning and increased pulmonary vascular resistance. And of course, under inflation, will have the problem will be with ventilation itself. So we really don't want to come to that place here. But the other problem with the hyperventilation and it came into stages. We stayed years using has to be CO2 less than 25. But people who start to recognize the problem, then we say, no, you know what, we're just going to keep it in the 30s. It doesn't have to be, then until finally things get changed, and now we don't hyperventilate at all. But the other problem is that alkalosis itself shifts oxygen dissociation curve to the left, that meaning that you'll have a less tissue oxygenation, and also will decrease alkalosis. Dr. Aldib will present that today, that alkalosis or low CO2 can actually also decrease the cerebral vascular blood flow. So you are decreasing to the oxygenation of the brain. And there are studies showing neuronal hearing loss. Many patients of ECMO, they have hearing deficit, and we refer to that, is it because of hypoxia before ECMO, or is it because of the alkalosis? And we don't know why there is a relationship between alkalosis and hearing loss. Is it because the alkalosis in the inner ear fluids burn out the nerve fibers of the auditory nerve, or we don't really know, but we know that or is it something central? Like there are studies done on monkeys where when they are alkalotic, there is decreased cerebral blood flow specifically to the auditory center in the brain that is mostly affected. And we all aware of this, the oxygen dissociation curve. So what we call it the P50. So the P50, which is it's the point at which 50% of the blood, of the oxygen will dissociate. That's why it's oxygen dissociation curve. 50% of the oxygen dissociate from the red cells to go to the tissue, to the brain or whatever. So, and you can see when you are shift to left in cases of alkalosis, the 50% of oxygen will leave red cells only if the PO2 is around 10. So you have a baby with a PO2 on the blood gas 50 or 60, and saturation could be 99 or 98 or whatever. But actually, the brain will not see this oxygen unless really the PO2 is down to 10. It's not going to leave it. While when you are acidotic, you can see the dissociation from oxygen occurs at a higher level of PO2. And not talking about the hyperventilation itself, this is a patient who's left diaphragmatic hernia. There is an acute instance, and I just discussed, mentioned to you the transposition when we hyperventilate them and they get a pneumothorax. This is a patient with left diaphragmatic hernia and with some bagging, and you can see the pneumothorax, pneumopericardium, and subcutaneous emphysema, pneumoperitoneum, and died. It just doesn't require more than a few aggressive bagging to cause death of the patient. So really the use of bag, it's something really dangerous. And many times we see coming from delivery room to the NICU, bag, or for patient going for a procedure, you bag. We have ventilators now, and they have oxygen tank and air tanks, and you can move the patient throughout the hospital without the need to bag the patient. And there are actually studies showing that you don't need more than few aggressive bagging to damage the lung. And it can be permanent damage, not just a irreversible damage, as done in animal studies. So now we'll talk about the use of vasodilator the use of vasodilator. Dr. Wang, he mentioned about prescholine. I probably will not talk long about it because it was non-selective pulmonary that caused vasodilatation everywhere, and hardly we use it now. But then epinephrine, prostaglandin, magnesium sulfate. The problem with magnesium sulfate, there are a couple of studies published about it, but also it's non-selective, so you'll end up having a hypotension. And the whole idea is you need to selectively decrease the pulmonary hypertension without decreasing the systemic blood pressure. Then you have the inhaled nitric oxide. One of the issues when I mentioned about dopamine, many times we use dopamine to increase the systemic blood pressure. However, dopamine more than 10 mics per kg per minute, it does increase the pulmonary artery pressure. So many times a patient hypotensive, you start to escalate dopamine beyond 10 to go to 15 and 20, but actually once you hit above 10, you are actually causing pulmonary hypertension, and then you lose the effect. So we tend to use dopamine up to 10 only. Then if you still see hypotension, you can add something else like dobutamine, or you can switch to epinephrine. Then inhaled nitric oxide, we are all familiar with it. It works by relaxing the vascular smooth muscle with binding to guanylate cyclase. That will create or elaborate more of cyclic GMB. That is a local vasodilator. So the good thing about the nitric oxide, it is very selective. So when you are inhaling it, if you have a lobe of the lung or area of the lung that is collapsed, you don't want to send any nitric oxide to that area anyway, because if you dilate the vessels going to a lobe of the lung that is collapsed, you are actually creating more VQ mismatching. So you really, oh, really?
5 minutes.
Okay. Okay, so the good thing about the nitric oxide, it is selectivity, where it goes only to the aerated area, so it will improve the perfusion in an area that is well aerated anyway. I probably will skip to stick on time. Weaning of nitric oxide. Sometimes you take the baby of nitric oxide, you go all the way down to 5 parts per million, then you wean it off, and then you find the baby deteriorating. And in the olden time, we used to have babies stay for nitric for a long time because we are unable to wean it off. And actually, we just noticed that back in the 1997, that when you really wean nitric oxide, yes, you can have severe desaturation. And heart rate will come up and blood pressure will come down. Then when you give the nitric oxide back, you end up having heart rate, saturation, everything came back to normal. But let's try to wean nitric oxide one more time, but at this time with giving oxygen. So if you give abundant amount of oxygen, which is pulmonary vasodilator, the baby will not notice that nitric oxide is weaned off. And then you start to wean oxygen very slowly after that. So it took us 2 hours to bring oxygen back, or 3 hours to bring oxygen back to the pre-nitric level without really losing any. So we don't wean nitric from 5 ppm to 4 to 3 to 2. Just take it off at 5 while giving abundant amount of oxygen. Then after that, you start to wean the oxygen and take your time with that. So sedation, yes, judiciously, but no, if a baby heavily sedated with morphine and drips, he will be hypotensive, which you don't want to happen, plus all the side effects of the sedation. Nowadays, we have Presidex, which is good because it does not suppress your breathing, so you end up still spontaneously breathing, which is good, though it can have bradycardia and hypotension effect related to that. Paralytic agent, I just will read one line only. There is no place for paralysis in NICUs that plan to do gentle ventilation. Just, there is no room for it, basically. Maybe in the OR during surgery, but beyond that, the paralysis should really be avoided. And side effect of paralysis, that can be a different lecture. Like this baby was on 100% oxygen. And can you see what's going on? You can't. This baby was paralyzed. Really, it's just paralyzed. Take off paralysis, that's his x-ray after 24 hours of being off paralysis. Now I know why he's requiring that oxygen. You can't clean up lung and clean the secretion. So these are the gentle ventilation strategy, the Columbia strategy. All what we need for a baby with pulmonary hypertension is a pH greater than 7.25. CO2s 50s or 60s is fine. And then PO2 40 to 60s, no paralysis and judicious sedation. And this is a previous described in 1978. pH had to be more than 7.5 and CO2 and paralysis and sedation. As you see, it's really a complete opposite. So it's really the gentle ventilation is the most important, avoiding paralysis and stepwise use of pressors. So I just want to touch base in the couple of minutes left about the use of nitric oxide in premature infants. So many times when you discuss things, say, what is the evidence? And that is one of my anecdotal observation. Anytime you have something more aggressive, we don't ask for evidences. Like, for example, the hyperventilation of pulmonary hypertension. How come that all NICUs, nationally and internationally, is hyperventilating babies based on a study of 22 patients, non-randomized? We're happy with that. But then you start to use something gentle, bubble CPAP. Oh, what is the evidence? The Cochrane said what? So usually when you're trying to bring the care down more conservative, you are very hesitant. But to bring it up, the same thing when you are ventilating a patient. If he's desatting, you can easily increase the pressure from 20 on the vent to 25 in no time. But can you win it from 25 to 20? Never. You do it to 24, then wait 6 hours, and then 23. But you just yesterday increased 5 in no time. So that is really the fact of life. So when you go to nitric oxide, what is the evidence of use of nitric oxide in premature infants? So my question is, can you have pulmonary hypertension in a premature baby? Yes, no? Yes. Okay, so there is a need. Now, currently, can we identify who are these babies individually? Can you find who are the baby who's really having pulmonary hypertension versus a baby who is having atelectatic lung or who's having pneumonia or surfactant deficiency? So we have a problem with that area, the identification. But we don't have a problem with the acknowledging that pulmonary hypertension exists in premature babies. So if I'm going to give a one summary, if you know when to take nitric oxide off from a premature baby, then I have no problem, start it. But if you are going to start the baby on nitric and stuck the baby on nitric, then that's the problem. So for example, if I have a premature baby who is in 25% oxygen on CPAP, then overnight something happened, I don't know what happened, and the baby bradyed, deteriorated, got intubated, and next day you do in round, he was on 100% oxygen. And he's still desaturating even on 100% oxygen. This is not a surfactant deficiency because yesterday he was on 25% non-intubated. So that potentially can be a pulmonary hypertension. Can I try nitric oxide in this baby? with a predetermined, I'm going to give him a chance of nitric 3 days or 4 days, treating him as a pulmonary hypertension, and then I'm going to plan to wean it off. So the answer is yes. I don't see the major harm that will happen from that when I see a baby desating in the 70s. But the problem is every single chronic lung disease baby or baby who's on oxygen, when you start him on nitric and then you tend not to wean, that is a problem then. But when you are going to look to the clinical trials that were done on nitric oxide, and by the way, all clinical trials that were done on the use of nitric oxide in premature babies, they never did an echo. Because if you're going to do an echo on each premature baby, you'll be very hard to recruit the 1,000 patients required for the trial. So all nitric oxide clinical trials are used for babies with acute respiratory failure, very vague name, babies who are requiring oxygen more than that. That includes babies who have lung atelectasis, babies with secretions, babies with pneumonia. And then when you diluted the pulmonary hypertension piece of it into a huge population, all premature babies, then more than likely you're not going to see outcome that will show that nitric oxide works. So when you look to this 11th clinical trial, none of the trial reported any improvement in survival at 36 weeks, and only one combining two trials, or early routine nitric, which I don't recommend to give early prophylactic nitric oxide, there was marginal improvement in survival. Outcome, does it decrease BBD at 36 weeks? So none of the trial will show that, and that's the time over. And really, trust me, we're gonna visit this BBD thing at 36 weeks. No trial can show you decreased BBD in intubated babies. Once you have the baby intubated, nothing will work to decrease BBD. The key for prevention of BBD is not to intubate. But you intubate the baby and give surfactant, no BBD improvement. Intubate the baby and give whatever you would like to give is not going to work, because the injury from the tube is much bigger than any treatment that you will think of. So mortality and BBD, none of the studies showed that. Intraventricular hemorrhage. So basically there is some studies showing increased IVH and some others showing decreasing IVH. So basically there is no effect, neurodevelopmental outcome, nothing. But I just want to show you this trial from NICHD looked at 1 year of age, premature babies who received nitric. There is a favorable outcome for the use of bronchodilator, inhaled steroid, and systemic steroids are significantly less in the one who received nitric oxide. So basically they have worse chronic lung disease or less chronic lung disease when you are on nitric oxide. The problem of this one, it suffered that it did not follow up the entire population. So the follow-up rate was not great. So we don't really, we're not sure if that is really true or not. So the hospitalization within 1 year, not different respiratory hospitalization because of BBD, not. The use of diuretic significantly less, home oxygen, and you can see it here. It's really sad, but that is fact. 40% of babies are at home oxygen at 1 year. There is something wrong here. We really need to use CPAP rather than nitric and intubation. And then oxygen at follow-up, 3% and 9%. Well, that's significant. So no real short-term side effect when you give nitric oxide. So if that would be my conclusion from all the clinical trials, they didn't see increased mortality or something major. But the long-term risks are unknown. I know may be beneficial in certain subcategory of premature babies when therapy is used for certain duration of time. And that is really my final word about nitric. If you don't have an exit strategy, do not start it. You don't have a baby on nitric for 2 months. Thank you.